This is a recording for Steve Welty, a professor of clinical pediatrics at the University of Washington School of Medicine, who provided the content for this program on airway resistance. In the first module of this program, we will discuss resistance equations and their application in gas flow along the airways. By the end of this module, the learner will be able to outline the variables that affect airway resistance when airflow is laminar, describe the relationship between airway resistance and radius of the airway in laminar and turbulent flow, and discuss the relationship between pressure drop along an airway and airflow. An equation of motion is an equation that describes the behavior of a physical system in terms of its motion as a function of time using dynamic and static variables. When applying the equation of motion to the neonatal airway, there are a variety of dynamic variables to consider. These variables include the resistance, pressure, and airflow. Elastance, which is the reciprocal of compliance, is considered a static measurement. When you think about the characteristics of the neonatal airway and lung parenchyma, it is easy to imagine that these variables are altered at different points in the proximal versus distal airways. Whether by spontaneous breathing or invasive ventilation, the equation of motion indicates that the force required to give momentum to a particle is equal to the sum total of elastic, resistive, and inertial forces. During spontaneous breathing, the pleural pressure decreases and increases with inspiration and expiration, respectively. The magnitude of these changes is determined by airflow, tissue resistance, and elastic forces in the lungs and chest wall. The equation of motion describes the total driving force for breathing, which allows airflow from the atmosphere to the alveoli as the sum of elastic, resistive, and inertial forces. In most cases, the inertial forces are small and can be ignored so that the pressure applied to the respiratory system just needs to overcome the elastic and resistive properties of the lung in order to provide alveolar ventilation and gas exchange. When breathing spontaneously, the pleural pressure is negative relative to the atmosphere. In the case of invasive and non-invasive ventilation, the applied pressure is higher than atmospheric pressure and becomes the driving force for ventilation and subsequent gas exchange. A portion of the total pressure created or applied is needed to overcome the elastic properties of the respiratory system to change lung volume. Another portion of the total pressure is used to overcome the resistive characteristics of the respiratory systems to create airflow. The pressure required to address the elastic properties of the lung is directly related to volume and inversely related to the compliance of the airway. In other words, if the lung is compliant, it does not take much pressure to distend the lung. Resistive pressure is proportional to both flow and resistance. The total pressure required for movement of gas from the atmosphere to the alveoli is equal to the sum of elastic and resistive pressures. This equation shows us that driving pressure is directly proportional to volume, flow, and resistance, and is inversely proportional to compliance. For air to flow through a tube, there must be a pressure differential from one side to the other. In other words, P1 must be greater than P2. The pressure differential across a tube, sometimes referred to clinically as the pressure drop, depends on the velocity and the type of flow. At low flow rates, the velocity profiles of airflow are parallel to the sides of the tube. This is called laminar flow. As the flow rate increases, or in areas where the size of the airway change dramatically, the characteristics of flow changes to a turbulent flow pattern. In turbulent flow, streamlines are no longer parallel, and disorganization of flow is seen. In simpler terms, laminar flow is smooth, while turbulent flow is rough, and by definition not as efficient, so that it stands to reason that more pressure may be needed to drive turbulent flow. In laminar flow, air flows parallel to the sides of the airway, and the velocity profile is orderly in moving from high pressure to low pressure down the airway. At low velocities, air tends to flow without lateral mixing or cross currents. Due to frictional forces at the walls of the airway, the flow in the middle of the airway is faster than at the periphery. In the setting of laminar flow, the relationship between pressure, resistance, and flow is described by Pusali's law. We can solve for flow by rearranging the resistive pressure equation, which is pressure equals flow times resistance. This equation shows that flow is the product of pressure drop from P1 to P2 multiplied by pi multiplied by radius to the fourth power divided by the product of 8 times gas viscosity times the length of the tube. In laminar flow, airway resistance is directly related to the length of the airway and the viscosity of the gas, and indirectly related to the radius. It is clear that both the width and the length of the airway impact resistance, but the width of the airway has the dominant effect on resistance. This equation shows you that if the radius of the tube is cut in half, the resistance increases 16-fold, but doubling the length of the tube only doubles the pressure. Turbulent flow has different properties than laminar flow. Turbulent flow does not adhere cleanly to Pucell's law. Instead, the pressure in turbulent flow is directly proportional to flow squared and resistance. The pressure drop across a tube with turbulent flow is greater than that required for laminar flow. Unlike in laminar flow, density is an important determinant of resistance. An increase in gas density increases resistance and the driving pressure in turbulent flow. Despite the difference, resistance in turbulent flow remains directly proportional to length of the tube and inversely proportional to the radius. The complete calculation of resistance in the setting of turbulence is complex and outside the scope of this presentation. In general, turbulent flow is found in larger airways, at airway branch points, and areas where airways change size, such as in the subglottic region. Abnormalities such as subglottic stenosis, tracheal edema, as can be seen with croup, or airway secretions can lead to turbulent flow. The Reynolds number, a dimensionless number, can be used to predict whether airflow will be laminar or turbulent. In this equation, density and velocity are in the numerator, and viscosity is in the denominator. This provides a ratio of inertial to viscous forces. Turbulent flow is more likely to occur at high Reynolds numbers, when the velocity of the flow is high and the radius of the tube is also large. Another way of thinking about turbulent flow is that the inertial forces dominate over viscous forces. Heliox, which is a mixture of helium and oxygen, has a lower density than pure oxygen. Heliox is often employed in situations where high turbulence from obstruction complicates ventilation. The Reynolds number is increased by increasing flow and density of the gas and the radius of the tube. The Reynolds number is decreased by decreasing gas velocity. The Reynolds number is used to predict when there will be laminar versus turbulent flow. When the Reynolds number is less than 2,000, the flow is laminar, and when the number is above 2,000, the flow is turbulent. Clinicians take advantage of this relationship and use lower density gases, such as heliox, when managing patients with respiratory pathology that leads to conditions with large Reynolds numbers, like upper airway obstruction. In the NICU population, the most common indication for heliox use is bronchiolitis. Please take a moment and pause this slide to compare and contrast laminar versus turbulent flow. All respiratory systems have a combination of turbulent and laminar flows, and this certainly holds true for the neonatal airway. The pressure drop, or delta P, required to ventilate the lungs is the sum of pressure drops of both laminar flow and turbulent flow found in the respiratory system. In the next module, we will explore how resistance changes throughout the neonatal airway from the nasopharynx to the alveoli and how it impacts breathing.
We would like to acknowledge the American Academy of Pediatrics, the Organization of Neonatology Training Program Directors, Neo Reviews, and Abbott Nutrition for their support of this educational program. This concludes this module.